Rebecca Edwards, and I am going to go over the palliative care section of our cancer webinar. So what is palliative care? Palliative care is an approach that improves the quality of life of patients, and that it includes both adults and children and their families. And I would also add potentially caregivers who are not necessarily blood-related family members who are facing problems associated with life-threatening illness, and we often call that serious illness. It prevents and relieves suffering through the early identification, correct assessment, and treatment of pain and other problems, whether physical, psychosocial, or spiritual. This is the World Health Organization definition of palliative care. So we think about palliative care as multidimensional, and it really is an extra layer of support that can be introduced and should be introduced early in a serious illness trajectory. So really at the time of diagnosis of a serious illness, palliative care can become involved, should become involved if available, and offers an extra layer of support and continuity for patients, families, caregivers. The advanced practice nurse is very much a key player in palliative care. I would argue that advanced practice nurses in the United States and some other settings really have the most autonomy in palliative care when compared to other specialty areas. It's really an ideal position for an advanced practice nurse to be in based on the improved autonomy in this particular specialty area. So really understanding the patient through doing a comprehensive assessment. And you can see this cycle in this multicolor circle that really is inclusive and holistic. So we're not only considering physical symptoms such as pain, fatigue, delirium, et cetera, physical function, but we're also incorporating what is the emotional burden for the patient. Is there anxiety? Typically there is. Is there depression? Very typically there is. Are they having coping issues? Is there any form of denial? Are they not adjusting well to their illness, which would be very common. In the green, social relationships and their social support system is very, very meaningful when considering palliative care. So we really need to incorporate our thoughts and our plans based on the support that a particular patient may have who is facing serious illness. So this would be family and other caregivers, relationships that patients may have. They may be healthy relationships, they may be unhealthy relationships, they may be detrimental, they may be, beneficial. And we have to think about living situations. Where do these people live? What's their home setting? How far away from clinical services? And are there financial constraints? And what are we going to do about that? We definitely need to also incorporate spiritual layers into this. And spiritual can have a very broad meaning. It can be religious, it can be faith-based. It can also just be, how that patient finds meaning in their existence and in the world and who they are. And do they have hope? Because hope is very important, even in the setting of advanced, poor prognosis cancers. And we certainly want to make sure that we're maintaining dignity, which is another component of spirituality. Informational is not often, incorporated in this circle of physical, emotional, social, and spiritual, but I think it's also very important to think about the prognosis. Do they understand their illness? Is there any kind of health literacy issue? Are they really understanding what's going on? And are we being clear in terms of prognosis and expectations? What are their treatment risks? I think sometimes this is not very well explained to patients. We talk about chemotherapy or immunotherapy, and we talk about potential, risks, but what is really the lived experience of patients who go through these treatments, radiation, surgery, et cetera? We need to make sure that patients have advanced care planning in place. Do they have a representative who can represent them if they are not of sound mind and cannot make decisions on their own? Do they need home care? Is home care available? So as you can pharmacy, the advanced practice nurse would certainly be involved in all of these different components of palliative care, and each one is just as important as the next. So it's not just a focus on physical, it's a focus on the holistic experience of the patient. So palliative care is team-based by nature. So palliative care nurse practitioners, advanced practice nurses are very integrally involved with the patient and their caregivers. You'll see the nurses kind of in one of these upper circles. There are also multiple other team members, all of equal importance, physicians, social workers, psychologists, volunteers, pharmacists, physiotherapists, occupational therapists, chaplains, other spiritual figures, case managers who are often either social workers or nurses. And then in the inner circle, the families or caregivers. And then that circle inside that we talked about of this very holistic way of looking at a cancer patient and their experience. So what is a comprehensive palliative care assessment? So want to make sure that we're timely. We want to not have delays in things like symptom management. Certainly if you or I were experiencing pain or other symptoms, we would want to make sure that, you know, our clinician was staying on top of that. Advanced practice nurses are often thought of as the experts in symptom management, whereas the physicians are thought of as the experts in, you know, treatments and treatment planning. However, that does vary somewhat in palliative care because a big component of what we do in palliative care is symptom management. So physicians are also very focused on this, and it's really, again, a team-based approach to taking care of symptoms. We want to make sure that they've maximized their cancer treatments, you know, based on their wishes. So in the green line going across, we want to make sure that they're, you know, getting treatment if they want treatment, if there is any benefit to the treatment, and making sure that that information is clearly communicated. We want to make sure that the symptom burden is as small as possible, that we're getting optimal symptom control with medications and other avenues, non-pharmacologic avenues where we can maximize symptom control. Moving forward to psychosocial support in the red box in the middle, we want to make sure that we are taking care of our caregivers, making sure that they're informed and we know their role with this particular patient, trying to minimize anxiety and depression, which is very, very common in the setting of cancer diagnoses, making sure that the patient and caregivers have proper spiritual care based on their culture and their wishes and their beliefs. And then moving forward from there, making sure that we're communicating and making decisions as a team of providers and clinicians, but also as a team with the patient and caregiver who are considered an integral part of our team. So we want to make sure that we're trust building, we're relationship building, we are having end of life discussions, thinking about planning ahead based on the prognosis, making sure we're clearly communicating prognoses in the best way possible for that particular patient. And talking about cancer treatments at end of life, whether there's no utility to any further interventions that are cancer directed, and should we focus on comfort and should we focus on support in a holistic way. In the blue boxes, we want to, you know, by doing all of these things, by focusing on symptom management, psychosocial support, and making sure that communication and decision-making are maximized, our outcomes will be improved. And that would include quality of life, reduced suffering, better symptom control, better satisfaction, less aggressive care, which is often more beneficial, and, you know, potentially more prolonged survival, because there are several studies at this point that show that steering away from futile care and focusing on comfort and supportive measures in palliative care can actually prolong survival. The first of which study was based on later stage lung cancer patients, and that study showed an improved survival. The primary author was Temel, Temel, Jennifer, out of the Boston system. So many studies have been produced after that time that show prolonged survival for multiple cancer types with palliative care integration and avoiding futile care. So definitely a benefit to palliative care if it's available, when it's available, and if it's incorporated in the right way. So we think about palliative care as proactive. We want to make sure that we're preventing. We're assessing early and preventing things that can be problematic for patients and families. So components of preventive care would be like an insight to illness. What's the natural history? What's the prognostication, which we talked about in the diagnostic portion of this particular cancer webinar? Can we prognosticate? Are there tools available? What's our best guess at how long a patient will survive? So for example, one, on the first line, a patient with stage 4 pancreatic cancer tends to have very high symptom burden. They have a very short prognosis. So example 2, we want to make sure that we're advanced care planning. And in example 1, we want to make sure that we're symptom managing. And that may be incorporating not only medications and non-pharmacological treatments, but thinking about spirituality and thinking about psychosocial issues that can contribute to symptoms. Then the second line, with foresight for the individual, we need to anticipate concerns and think about risk factors. So mild pain can get worse. So just make sure that the patients are aware that their experience today may not be the experience tomorrow or next week, and that there is an expectation that the patient and the symptom burden and the experience will deteriorate over time based on the serious illness process. So making sure that the patient has foresight and that we're allowing for that to happen. In terms of the third line, interventions when available, we want to make sure that we're reducing risk and we're using evidence-based practice. So for instance, with pain control, certainly opioids are very important and are readily available in the US and other regions. And most regions at this point have made opioids available, but there are still barriers to opioid use in certain regions. So we need to consider that. And making sure that we're having serious illness conversations, regardless of the resources. What do people understand? What interventions are available? And what's the best course of action based on resources? Introducing the intervention, so making sure that we're, initiating whatever intervention it may be based on the patient wishes and best evidence and, the comprehensive assessment. Are we initiating things in a timely way, and are we following up? So it's not just a one-time decision, it's a decision over time as things evolve with the serious illness, the symptoms evolve, the experiences evolve, and we need to be making sure that we are staying on top of all of that. So it may be that we're starting scheduled opioids, educating, monitoring, keeping track of a patient, bringing them back in if possible, communicating by other mechanisms such as telephone or texting or whatever way is possible, telehealth when possible, and thinking about prognostic discussions as the serious illness progresses, and making sure again that the advanced care planning is in place. So that would be, having a proxy, someone to make decisions when the patient is not able to, knowing the patient's wishes for end of life. Do they want aggressive treatment? Do they not want aggressive treatment? Have they been well educated on that, et cetera? Crisis prevention, we want to make sure, and this final line here, that we are preventing crises when possible. We want to improve outcomes, making sure preparations are in place, focusing on quality of life, avoiding pain crises, making sure the patients and families and caregivers have what they need available and are well educated, and focusing on the better quality of end of life, avoiding aggressive treatment, futile treatment that can be very burdensome and awful for patients and families. So as you can see, this whole picture really speaks volumes about palliative care and how we want to be proactive about assessment and prevention across the serious illness trajectory for all components of palliative care. So in terms of levels of palliative care, the more accepted levels of palliative care at this point are the first block here in red, primary palliative care, which is something that really any provider, not specialist palliative care providers, but any provider in primary care and oncology and cardiology, pulmonology, nephrology, you name it, has the ability to accomplish. So the thought is that all clinicians, including advanced practice nurses, need to be tuned into primary palliative care, and so that the most complex patients will be reserved for those with specialty training in palliative care, and that would include the team, such as physicians, advanced practice nurses, et cetera. So I started to say that the more accepted terminology is primary palliative care, which I just explained. And then in terms of the other layers of palliative care, secondary and tertiary palliative care are explained here on this slide, but I prefer to bundle these together and use the term specialist palliative care. So primary palliative care is palliative care that can be provided by any practicing clinician, and it includes basic symptom management. Referrals are a very important component of primary palliative care. So a referral to palliative care specialists when needed, because the patient's complexity is just too great for other settings. And in terms of the secondary and tertiary primary care that I have bundled into specialist palliative care, this really involves specialty training in palliative care, which is available for both advanced practice nurses and physicians, as well as other disciplines, by a variety of different mechanisms. And there is a big push in the United States and in other places to have more specialist palliative care education available, and also to integrate primary care principles into basic curricula for health professionals, so that everybody has some sort of some sort of palliative care training. In terms of specialist palliative care, these teams take care of the most complex patients. You saw the components of the team, including the patient and caregivers and family. You saw the holistic approach to palliative care, including physical, social, psychological, communication, informational, spiritual components of palliative care. And specialist palliative care trained clinicians are really the experts and should be taking care of the most complex patients. And all clinicians should be able to recognize when a patient is so complex and their situation is so complex that they need specialist palliative care. And again, advanced practice nurses are really integral in all of these aspects of palliative care, from primary palliative care to the most complex cases in specialty palliative care. So where does palliative care happen? Ideally, it should be happening across the healthcare spectrum. You will find that even in the US and in higher resource areas, that most palliative care takes place in hospitals, and there's less palliative care available in the community and in clinics and in skilled nursing facilities and at home. And then, of course, there's a layer of hospice or end-of-life care that falls under the umbrella of palliative care. So we are, certainly pushing in the palliative care field to make palliative care accessible across healthcare settings. In certain regions of the world, there is no palliative care. In certain regions of the world, there is very minimal palliative care. In certain regions of the world, palliative care is only available to patients with cancer and not other illnesses. And palliative care is intended to be available for any patient with a serious illness, not just cancer. So you may find, depending on your region, that there's no palliative care or there's a lot of palliative care. But I would argue that in almost any setting or in all settings, that palliative care is mostly based in hospitals, and that clinic availability and community availability and skilled nursing or nursing home availability and home settings in the community and home hospice, for instance, and dedicated hospice facilities are more rare as the resources are more poor for the most part. And that is not always the case, but this is where we are in the world right now, and there are reports of this, and we are getting better and better in the US in terms of palliative care availability, but we are very regionally different in our country, in the US, where palliative care is readily available in some states and not so readily available in other states. And the deep south of the US tends to be one of the pockets of areas that do not have as much palliative care availability. However, that is improving, such as in Alabama, where some of the more rural areas don't have ready access to palliative care, but we are working to improve that situation. So models of palliative care, there are many models, and you'll see different names for these types of models. But just as an example, there are freestanding clinics where available, where it's dedicated to palliative care only. And there are certain benefits to that where you may have more expertise and the palliative care management may be better, but there may be cost issues. There may be difficulty with kind of reaching other clinic visits or other hospital visits because this freestanding clinic is dedicated to palliative care. So beneficial in terms of the palliative care that may be delivered in these clinics, but maybe detrimental in terms of cost and other factors. But certainly advanced practice nurses could be, running these clinics in the US, or they can be an integral part of these clinics in the US and other areas. Embedded clinics are, such as we talked about with the interprofessional cancer care, where there may be medical oncology and surgical oncology and radiation oncology. There also may be palliative care available in these clinics for patients who need that. So again, primary palliative care should be something that the medical oncologist and the radiation oncologist and the advanced practice nurses from those areas can handle. But when the complexity gets too great for a patient and their family and caregivers, we may be able to pull in a palliative care specialist, maybe an advanced practice nurse or a physician, maybe a social worker, depending on the care needs for that particular patient. And the benefit to that would be the convenience of seeing other specialists, such as the oncologists and the oncology specialists, but also being able to tap into palliative care for, for instance, spiritual care or, high symptom burden or things like pain that's difficult to manage. So both of those first two have certain benefits and certain restrictions or barriers. And then in the US, we do have some nurse-led practices where nurses really lead the palliative care. There are, it's great because nurses, again, especially advanced practice nurses, are I think ideally suited for taking care of complex palliative care patients, and our autonomy is quite good in some states, but not all states in the US. And I think we're really, really good at this. I think that advanced practice nurses can really kind of reign in this area and do a wonderful job. And there are several studies that show that we can do just as good of a job, if not better, than physicians. But there are certain barriers to nurse-led practice in the US, depending on the state, depending on the insurance. There may be reimbursement issues. There may be difficulty with staffing, and there may be heterogeneity in these types of practices. So some may be really well run and some may not be really well run. So that's what we have for palliative care. We could talk about palliative care all day. It happens to be a love of mine. So I know that you're going to be given our information to reach out to us if you have specific questions regarding any component of this cancer webinar, but I'd be very happy to answer any questions at all, but would probably be most happy to answer palliative care questions just because I have a true love of palliative care, particularly for advanced practice nurses. So good luck with the rest of the webinar, and that's it for this particular section.
Hello, everyone. It's Dr. Richard Taylor again from UAB, and I'm going to give a brief discussion or talk about survivorship, cancer survivorship. And since this is really a very huge and can be very complex topic, I'm just going to give a brief overview and encourage you all to do more reading and more investigation of this topic. So I'd like to just start with sort of an overview, a conceptual approach. Much like my other lectures that I have given for this webinar, I've really focused on the quality of life domains. And I think this is really an important and nice way to ground survivorship care. And as we have, or as I have talked about earlier, the cancer and its treatments has impact on each one of these domains. And as you see here, just by this diagram, the overlap they overlap in certain areas. So that is one really nice way to kind of frame survivorship care and look at those things that impact the patient's quality of life. And most patients are very interested in quality of life, sometimes more so even than survival. So this is where your exploration of the patient's goals of care and their values play really important into all aspects of survivorship care, not only the patient, but also the caregiver, because we have talked about the caregiver throughout the series, is that they are oftentimes the social network support for the patient. And oftentimes, if the patient's not able to make informed decisions themselves, then the caregiver is responsible for enacting or honoring the patient's wishes. And so that, coupled with the cultural underpinning of for both the patient and the caregiver, what is important to them culturally, really should frame the whole survivorship care, and as far as I'm concerned. And we remember this cancer care continuum here. We are revisiting this, and I'm going to go over these survivorship sort of areas here. And as we talked about earlier, that a cancer patient is a survivor from the time of diagnosis. So that means that survivorship care actually starts at the time of diagnosis, right? And so that is how I'm framing this talk today. And we talked about earlier that these things happen both an outpatient and inpatient. And as a advanced care provider, a nursing provider, then your role, depending on what setting you're in, would also sort of guide or dictate what interventions you would be performing, particularly care planning, psychosocial support, assessment of staging, evaluating patients for surgery treatments, and then evaluating them for post-intervention or post-treatment side effects. And then moving into surveillance and screening. And we'll talk about those a little bit in just a second here. I want to remind you that palliative care it is suggested that it begin at the time of diagnosis, and oftentimes people have problems with this label, and we use the term supportive care because that's what we do, is support patients through across the entire cancer continuum. I want to also remind you that the cancer patient population is increasing significantly, and that older adult cancer survivors are a unique patient population and have different survivorship sort of needs compared to perhaps a younger breast cancer patient or cancer patient, other type of cancer patient. Their roles are different in life. Younger patients may be working, older patients may be retired. There may be social support networks are oftentimes fairly large for younger patients, but they shrink as the patient becomes older, so their social networks and their social support systems may be less. And the Institute of Medicine, in their important work, their book on really from cancer patient to cancer survivor, this Lost in Transition, and this was an important document, and it really sort of highlighted 4 sort of major areas, and we're going to touch on these, framing them in the phases of or seasons of survivorship. Really, prevention and recurrence of new cancers or other late effects. We're surveilling for cancer spread, reoccurrence, secondary cancers, any medical or psychosocial late effects. And as the advanced practice nurse, you would be doing these sort of prevention or looking for new cancers and surveilling for their reoccurrence and their effects. Interventions for the consequences of the cancer and its treatment, whether that be medical, psychosocial, psychological, both for the cancer patient and the cancer, or the cancer survivor and the caregiver. And oftentimes these may surround issues of employment, insurance, disability. Should I go on disability? I can't get disability, so therefore my income is very low. I've lost my insurance. All these sort of issues that surround survivorship. A critically important aspect is coordination between the specialists and primary care providers to ensure that all of the survivors' health care needs are met. Because cancer survivors certainly have other medical conditions, and particularly older adult cancer survivors oftentimes will have multiple comorbidities and be on multiple medications. Some older adult cancer survivors may be on 10 additional medications. So we have a chronically ill patient with perhaps cancer layered on top of that. And that doesn't, so the primary care provider is really important in managing those other comorbidities and the issues related to them. So part of the advanced practice nurse's role in cancer care and survivorship is to make those connections, to make sure that we are communicating clearly from a cancer provider standpoint to the primary care provider. Oftentimes primary care providers will say, we feel really left out of the whole care for this particular patient, and we don't know what you want us to do, and we feel like that oftentimes the patient is sort of given back to us, and we don't have the history of what's going on, and particularly what side effects or late-term effects might occur from the treatment, the cancer treatments that you are asking the primary care provider to monitor. So critically important communication and collaboration. So I wanted to sort of divide the survivorship, cancer survivorship, into seasons. And this was Dr. Mullen's original work. And when he was a physician that was diagnosed with cancer, and his own experience sort of informed these seasons, as he calls them. And so the first season is this acute survivorship season. And it begins at the cancer diagnosis. And it really is dominated by diagnostics and treatment based on the specific cancer type. So each cancer type will have their own unique survivorship needs, and based on the treatment and also the type of cancer and the symptoms that might occur from that particular cancer. And really, it's the goals of care that are really important. They're what do you want? Asking the patient, and we don't really get that information unless we clearly communicate with the patient and ask, what are your goals of care? Just because I'm the cancer care provider, and I may think that chemotherapy is very best for this patient, they may have different thoughts. Perhaps from a cultural standpoint, chemotherapy or treatment is not valued or not desired. They may be fearful about the side effects. They may be desiring not to pursue any treatment at all. So I need to know that in devising the survivorship care plan. Oftentimes this phase is fraught with a lot of fear and anxiety. And I think this is a great picture here. What if, then what? So it's these constant cancer survivors describe it as I can't turn my mind off. It's just constantly thinking, what if this? And if I do that treatment, then what's going to happen? If I do this, what's going to happen to my insurance? How is this going to impact my family? So cancer survivors often describe it as they feel like they're juggling multiple balls. This phase is also very focused on symptom management. The patient is oftentimes confronting mortality. I'm a young cancer survivor, and I've got 2 young kids, and I've got a husband, and what is going to happen? And they've told me this is a very serious cancer, and I may not survive. So a lot of those thoughts are going through. And our challenge as the advanced practice nurse is to address those, ask the patient those pointed questions, to get your interdisciplinary team involved. If it's you need a chaplain, if you need a social worker, if you need a psychologist, once again, think holistically. Support systems and coping styles are really important to also inquire about and put those systems in place to help support not only the patient, but the caregiver. The extended survival season, it really begins with remission or end of rigorous course of treatment, because oftentimes the patient is not put into complete remission. There are groups of patients in this season, and those are patients that are in remission and not receiving any maintenance therapy. So they've gone into remission, they're good, they're on their way. There's also patients that no evidence of disease, but they are continuing to have treatment. Then there is the group that is treated but not cured and living with advanced cancer as a chronic disease. What dominates this sort of phase or season is watchful waiting. There's a degree of uncertainty about the future, fears of and impermanence, what's going to happen. Is this really going to work? Is the cancer treatment, am I going to stay in remission? Is it going to, the treatment that, if I'm not in remission, is the treatment going to continue to work? You have periodic examinations. But this is where the medical team is not as critically important or involved as they were in the acute phase. So oftentimes cancer patients and their caregivers will have this tremendous amount of fear, like, oh gosh, I was seeing you every week, and now you're not going to see me for 3 months, and we're not going to get an MRI, and kind of what if the tumor starts growing back, and how will I know? So the advanced practice nurse is really involved in identifying and discussing those fears, those anxieties within the context of what are their goals and what's of value to them. And as I mentioned here, the actions for the advanced practice nurses, really monitoring. You monitor for cancer and also the long-term effects, and doing a lot of diagnostics that are necessary to continue to monitor and follow these particular effects of cancer and the treatment. Side effect management, oftentimes patients will have chronic long-term symptoms such as fatigue. They may have peripheral neuropathy, they may have cardiac toxicity that are long-standing now with the cancer treatment, and it's a matter of monitoring those. And then constantly connecting patients to the appropriate support system, whether that be support groups, maybe that is involving the patient with, as I mentioned earlier, therapy, psychological therapy, perhaps in checking patients and asking them about their employment issues, connecting them to insurance providers that are people that are very knowledgeable about insurance, that perhaps they lost the insurance and they need to get additional insurance. If you are not in a country that has universal care. And then the season, permanent survival season. And roughly this is equivalent to cure. And it's a period where the activity, where there are the cancer or likelihood for it to return is sufficiently small that it would be considered permanently arrested. And I really like this picture, and this patients will oftentimes describe themselves as Humpty Dumpty. And there's actually the Humpty Dumpty sort of syndrome where they feel like they've fallen apart with cancer and all the things that happen in their life, and they're just being sort of held together with some Band-Aids. And I think this is really a great representation of that. And so we, as advanced practice nurses, need to really think about, once again, those quality of life domains, but how are things coming back together Are they coming back together? And what are the things that we need to sort of follow along with the patient and the caregiver? What's important to them? While that, oftentimes I'll have to say that marriages do not survive cancer and its treatment. And so now we have the grief and loss of a relationship. And we may have other issues such as childcare and that's associated with perhaps a divorce. There are all kinds of things that the patient has experienced. And I want you as the advanced practice nurse to broaden your concept of survivorship and really think holistically about those quality of life domains and how the patient feels. And oftentimes they won't verbalize this. You have to ask. So what are the particular actions for the advanced practice nurse? And it's really centers around monitoring again for the secondary cancers or second cancers that may occur as a result of a cancer treatment. Long-term effects, I mentioned those earlier: cardiac, neurological, hearing loss, bone health, oftentimes with certain types of treatment. Very, very important. They may have developed endocrine issues such as diabetes from cancer or its cancer treatment. Fertility, fatigue, all of these things that you see listed here are critically important. So what do we do about that? And whatever is sort of the long-term effects that we anticipate, and it's difficult to give you the detailed information on that. It's really based on the cancer type. A breast cancer patient will have different survivorship needs and survivorship things that need to be followed from, let's say, a metastatic colon cancer. So really, it depends on what the cancer is and what the treatment was for that particular cancer that you develop a cancer survivorship care plan looking at these issues here. Once again, always connecting to the appropriate social support systems, what are services, whatever they may be. This is a modified version of the original seasons of Survivorship by Miller, and it really kind of gives a very nice graphic of how this you can kind of think about this. Acute, as we talked about, the transitional care is what is the new normal? I've transitioned from the acute treatment, but what is really the new normal now? Does it return to normal, or is there some new normal? And the patient adapting to that new normal, and the caregivers adapting to that new normal as well. Oftentimes, it's very, very stressful for caregivers because perhaps the cancer survivor was the breadwinner of the family, and now they are not. And the caregiver, the cancer survivor may have some profound neurocognitive impairments that now the caregiver is not only the primary breadwinner and holder of perhaps insurance and childcare, but also caring for their spouse that's not really the same as when they married them. And so there's a lot of anxiety, fear, uncertainty about how to do that. So our role as the advanced practice nurse is really to get in there and find that information out and what can we do support-wise to help with that. And so the extended survivorship plan care here is really talking about that 5-year period of observation and cancer surveillance after the initial diagnosis. And that 5-year mark is a very broad landmark, and it's not really exact, but most people, cancer survivors and oftentimes providers, will use that 5-year benchmark as the sort of the extended cancer survivorship phase. And really that phase is focused on quality of life and, like I said, impact on employment or relationships, et cetera. And then the chronic survivorship is really referring to this large growing number of cancer survivors that maintain a complete or partial remission, and those patients who continue to receive some type of therapy over the years. And so they're in a chronic survivorship, and their life may or may not be sort of normal again. And the fear of disease progression, the increased disease burden, the burden of the constant treatment can be profound. And so this is where we, once again, as advanced practice nurses, get in there and ask those questions and talk about those the impact. And then the permanent survivorship is that greater than 5-year period. And once again, we go into those people that are cancer-free or people that have some type of secondary cancer. So this is the sort of the long-term impact of cancer. So that's sort of my discussion of this. Once again, a very 30,000-foot level, because the time limit is very short for this presentation, but I do encourage you to use the references that I put in the reference table for you here, and really to kind of give you a beginning knowledge. And once again, I want to reinforce the fact that cancer survivorship really is dependent on the quality of life domains, the goals of care, the patient's values, and each cancer type and its treatment have different cancer survivorship needs and trajectories. So it's really important to look at that for each disease or cancer, but also the age group, critically important. So thank you for your time. And with that, we will end this brief presentation. Thank you.
Thank you for participating in these webinars. We have hoped to share with you some of our experience in caring for patients with cancer, and to share with you the roles of advanced practice nurses. In addition to the content that we've covered, you've met several advanced practice nurses discussing their role. It is worth noting that it's not always easy for the advanced practice nurse to take on these roles. What we have found is there are some conditions that enable the role, and then there are challenges. Certainly, positive relationships with physicians and administrators has been very important. Having good mentors can make a world of difference. But advanced practice nurses also need policies and regulations that support them in these roles. Some of the challenges that we've seen is role confusion, the role not being well understood by providers, by patients, by administrators. But we can address this with education of all players. There are regulatory challenges. For example, in the United States, licensure varies by state. So advanced practice nurses have full practice authority in about half the country and not in the other half. The other half require some form of physician supervision, which may range from a physician co-signing every record or seeing every patient to a nominal supervision that really exists on paper only, and there's no interaction between the advanced practice nurse and the physician. We've also have in many states limits on what the advanced practice nurse can prescribe for patients. Additionally, organizations and institutions may put limits on what a nurse can do and can't do for patients. Underlying these challenges is undervaluing the potential role of nurses. We know that nurses have so much to contribute to patient care, to cancer care, to care of communities. I'd like to introduce you to one of our students who is about to graduate as she discusses her role and her future role as an advanced practice nurse in cancer care.
My name is Michelle Ware, and I recently completed palliative care courses at UAB. I've been a nurse for 8 years, and most recently, I work in radiation oncology. In my current role as an RN case manager, I serve as team lead, supporting my fellow nurses and physicians. Most importantly, I guide patients through their oncology journey. I'm getting close to graduating, and I'm excited for the possibilities in a new advanced practice role. I hope to work as an NP in radiation oncology with a focus on addressing the palliative care needs of our patients who tend to have significant symptoms and complex care needs. I feel somewhat prepared to enter into an NP role, but I know I will need mentorship and guidance. My greatest challenge is that there is not a palliative care program where I work, so I want to create one. There will be knowledge barriers that will require the education of the physicians and staff about what palliative care is and how it is different than hospice. My goal will be to establish a culture of early integration. I have my work cut out for me, but I am hopeful that I will be successful in getting the opportunity to start a program. The palliative care courses at UAB have provided me a solid foundation, and moving forward, I will grow through mentorship, being active in the Hospice and Palliative Nurses Association, and through coursework provided by the Center to Advance Palliative Care. Thank you.
We would like to share with you some additional resources. There are websites of several cancer-related organizations that have guidelines for the management of multiple cancer conditions. Additionally, you can find the guidelines for resource stratification at these 3 websites. The Pan American Health Organization has several resources on their websites as well. And here are 3 additional websites that may be useful. Thank you.